right, so today I'm going to be talking to you guys just a primer, and nothing more than a primer on patient-physician communication. And because I think one of the things that we are challenged with, but it's also a great opportunity, is cross-cultural communication in clinics. Now, you're all going to be experiencing that in the next few weeks, and I think you already know, like I said, you already have some practical experience with regards to communication and what makes good patient-physician communication. But I just wanted to kind of set a baseline and give you this intro so we can talk about what you're about to see. So first we'll just spend like a couple minutes talking about what is culture, a few words about healthcare disparities, which you as a group I know are very invested and you already know a lot about health disparities. We'll talk about the theme of cultural competence, a couple basic tools, and then we've got a nice little practica that we can do. Crystal's been very nice to volunteer to help with a case. After the case, what I'd like to do is just hear your comments about what went well, what didn't go well, what you've seen, and that'll be it. We can have some questions after that and wrap it up. So it's a pretty brief presentation, and let's get started. So there's a lot of different descriptions of culture out there, but I like this one partly because it is so complicated. So it's an integrated pattern of behaviors that include language, thoughts, communications, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. I mean, that's just a lot of words, and that's a ton of variables. And so I think one thing that's important to recognize is that every patient truly has their own culture, and that's why I like family medicine, is because I get to know my patients. If you think that you can gain all of these different variables in one visit to clinic or a visit to the ER, good luck. I mean, some people are brilliant, they can pick out 2 or 3. But to really get to know all of them, it takes a while, and it takes really getting to know somebody. But this is where health happens. Knowing the person's culture is critical to trying to advance their health. So just throw things out there, like when you think of that theme, what are some of the aspects of your culture? Like, tell me about what you bring.
Very family-oriented.
Family-oriented, okay, that's good. It's an important part of your belief system. A couple more.
Religion.
Religion, okay, sure. Religious background, sure.
Language.
And language, okay. Those are great, and those are those are probably some of the big 3. If you took a top 10 list, that would be it. Any other thoughts on the culture? You're all different. Like I said, everybody's their individual. Anything else you share? Well, I would say that you guys haven't quite started medical school yet. You will very shortly, but this is going to be a lot of your culture over the next 5 years. So this is one thing you'll all share, no matter what your thoughts, beliefs, backgrounds, your families, your religion. Unfortunately, this is going to be a large part of all of your lives. And if you want to know the way faculty tend to think of ourselves and our culture, I was trying to think, I put something together, it looks something like this. We kind of have a certain authority figure with the brilliance of Madame Curie, but then also the sexiness of Brangelina, and that's the way we as faculty tend to view ourselves. So you'll get to know this really well over the next 5 years too, unfortunately for you. But culture really does matter, and I think when we think of culture, a lot of us kind of jump to the idea of race and ethnicity. That is really important, because almost 1/3 of U.S. adults are ethnic minorities, and minority status is kind of becoming a thing of the past. In California, there is no majority racial ethnic group, and the United States will look like that. Foreign-born, some of you are foreign-born, about 12% of the population is foreign-born, and non-naturalized foreign-born is about 7% of the population. So this is something that we encounter all the time in our clinics and really is an important aspect of people's health. And culture really matters because it matters in terms of the culture. There's another culture beyond race and ethnicity, culture of poverty, culture of educational attainment, and this culture of healthcare. And you can see that particularly Latino and African Americans lag behind non-Hispanic white groups in a lot of these markers in terms of poverty, in terms of educational attainment, in terms of having no health coverage, and then no usual source of care. Particularly for Latinos, those are critical issues. And so this is something that I think of on a daily basis when I see my low-income patients. And you have to keep in mind, because you cannot overstep yourself. You can't be recommending tests that are out of a person's means to try to control their disease. You can't prescribe the drugs that cost $200,000 a year. It becomes a difficult situation. But working in these populations, there's such a room to improve the health of low-income populations in that the services you do provide go a lot farther to actually making their lives better, improving their health. And so that's what I know your mission is, and we're here in Primal C to help you attain. So the health care disparities do have effects. So rates of mortality among African Americans about 30% higher than those among whites. You can see infant mortality and maternal mortality much higher. You all familiar with the Latino paradox? That despite these high rates of chronic conditions and higher rates of poverty, lower educational attainment, that the risk of mortality is overall lower among Latino populations. That paradox is kind of closing. The gap is closing between whites and Latinos. And the reason is, it's pretty obvious that the rates of these diseases are catching up. And then also violent death is something not to be excluded. This takes a lot of young people's lives in particular, who would otherwise live, 80 years, 90 years. It's a terrible tragedy. So among ethnic minorities, they're less likely to receive regular health services. They generally lack health maintenance, which is a big thing for me in family medicine. I'm all about health maintenance, and we could talk about how to achieve health maintenance in low-income populations. Less advanced care for both cardiovascular disease and cancer care. And there's a bias. Even when you take in every factor that you could, that includes healthcare coverage, and that includes educational attainment, income level. There's definitely a racial bias towards healthcare. We see it in the number of African Americans who are offered coronary angiograms. We see it among Latinos being discharged from the emergency department with long bone fractures. African Americans less likely to get the expensive test of the coronary angiogram. Latinos less likely to get adequate pain control. And yet, if you poll physicians, there's very much this, I see a consistent theme in the literature, it's not me. Well, yeah, I recognize that, I can see that statistic happening, but it's not my practice. And you hear that again and again. So while physicians have actually kind of come to understand that these biases exist because it's evidence-based, it's again repeated again and again in the literature, we see the same factor. Generally, they think it's somebody else's practice, and it can't be. It's all of our practices. And I think that we have to be aware of this and kind of own the problem together, because that's the only way you can really make it right. What does that make you think of? I just want to take a pause for any discussion or questions at this point. Or other ideas you have about disparities, does that kind of summarize it? Or did I miss something that you feel is important with regards to health disparities and how those disparities play out?
I think the question of legal status
Right.
could be brought a little bit more. That's also a big factor and barrier for a lot of people to themselves.
Right. And it's a reason that people don't go to clinic or hospital in the first place. We were talking about that earlier, why there's a stigma associated with going to the physician's office, which should be a safe place. And I mean, as a physician, I certainly think it's a safe place, but it's another institution. It's a place where you have to fill out 20 forms. It's a place where you have to, people are making copies of your ID. And, if you lack documentation, those are all really, scary kinds of processes to go through. Even if you think this might be a trusted place, you don't know. Again, that's where continuity comes in, and that's where having a strong reputation in the community comes in, because what I found is you need the grassroots. There's always a layer that you miss. I work in a federally qualified health center, so we're open to all. We are there for a community. A community board runs our entire practice, and so we see 55,000 patient visits per year, so it's a big operation in the middle of Santa Ana. But it's actually a group of 12 community members who decide the course of the clinic. Yet I know very much that we miss large sections of the community, the undocumented group being one of the largest ones, homeless being another one, people who are in abusive relationships. There is, people who are being held in bondage, because that happens in Southern California, not that infrequently. There's always a layer to get to, And I think the way you try to get to that next level is through grassroots. You need people on your side who actually live in the community, have contacts, use your services, and that it doesn't happen overnight, but when it starts to happen, you really can start having an impact and reaching out to those groups that are otherwise completely forgotten and disenfranchised. Any other thoughts? Yes?
I think part of it too is that you have to take into account like economic and just social aspects in those communities. Like,
Sure.
if you have links to poverty, I think it would be less likely that maybe you pursued education and you're informed about how to access like healthcare and like how to go about understanding what to do. So I think that poverty can be an impediment to accessing the information they need.
Oh, very much. That's absolutely right. I mean, you guys are way ahead of the game on this. And I think the trick in a busy clinic is to try to keep that in mind because you're processing a lot. And you'll see, one of the things I want you to experience the next few weeks is see how that process goes. I think some physicians are really attuned to it and better at it. Some physicians probably need more work in it. But I hope everybody at least thinks about it because you're going to be working in a low-income clinic. I think as well, the tough thing for me is to try to balance that with the medical side of things and finding time to fit it all together in a meaningful way and impart patient motivation and education because those are critical elements. If the patient's not motivated or if they don't really believe in what you're trying to pursue together as a unit, as a physician and a patient, all this stuff none of this stuff really matters actually. So it's hard. It's a lot of work, and it takes just years of experience, I think, to put that all together. You can see it on the slides and understand it. It's a different thing in real life situations, and that's why you're going into the clinics for the next few weeks is to have this experience. There's a couple of tools that might help you. Oh wait, I don't like the term cultural competence. It implies there's a certain arrogance in it, like I am competent in cultures. Every year, it just takes that one time when I'm seeing a new patient, and it's like, okay, so this is Maria Gonzalez, she's 62, I enter the room, hola señora Gonzalez, me llamo Dr. Vega, I speak English. That's like, just put it to me like that, it's like, oh, okay, I'll have it. And that's like my cue, like, okay, and I get on an automatic mode where I'm speaking Spanish and everything is flowing great, but yeah, that patient does not want to be addressed in Spanish, and so I learned that very quickly. And in fact, that'll become part of my chart notes, English. So I don't make the same mistake again in case she comes back 6 months later. Because then she won't trust me after that, she probably won't come back a third time. So the idea of cultural competence means like, I know everything, I've got this, and it just doesn't really resonate. Do you think of what other terms have you heard? What could replace cultural competence?
Cultural humility.
That's my favorite one. Because you really want to remain humble, and every patient should be treated, as an individual. And you can explore these issues, and patients often will like telling you about their preferences and their beliefs and their values. But yeah, cultural humility is my favorite. Cultural competence just works because it sounds there's a 2C sound, and that's why everybody picked up on it. But I don't really like that term at all. And I don't think it's desirable either, because I think one of the most satisfying aspects of practice for me is learning more about different cultures, and that's learning about people. That's one of the reasons I went into medicine. And you don't get to learn about people truly if you feel like you're competent in everything. So it keeps things, not only I think it's a better care, but it also is much more satisfying and interesting for me personally to get to know patients and learn about their individual culture. So there's a couple tools you can use. I really don't like the ethnic, which is because it's all out of order. There's explanation of the care and treatment, and then oh, by the way, you use native healers. Now let's negotiate and let's make an intervention and then finally collaborate. So I'm just going to skip it. This is the model I like. You listen. So always, I like it because it's more patient-centered. You always start with listening. Listening should be the primary thing you do as a physician. If you do nothing more than listen, you've already probably won the patient over. Which is great because you guys as pre-MS1s can't do much more than listen anyway. Because you're not really to this part yet. That's okay. But you could, I bet even at your level you can explain a lot. You could certainly acknowledge differences. It's perfectly fine to say, to make the turn and say, I understand that you're bringing this, this, and this is what you understand about it, and you've tried X, Y, and Z. The way we think about it, or the way I think about it is, A, B, C. And so what I'd like to consider is D, E, and F. Do they jive with X, Y, and Z? That's sort of your job, is to sort of get to that point. So you make a recommendation, which sometimes, your patients come into you for a reason. They're coming to clinic to seek your opinion. Now, whether they accept it at the end of the day, that will be their decision. But they at least want to hear something. So I see cases where people try to be too culturally humble and not actually go out there and make a recommendation. I'm a very positive person. I actually try to get out there, and if I feel like it's going to be effective, I tell my patients directly, I really think that this is going to help you. I think this could make you better. If you gave me pom-poms, I'd usually be like, yeah, and I'd exercise, woo, yay, mammograms. So I really find that helps me, and I try to give that to my patients, because if you start off a conversation doing recommendation where it's like, well, I'm going to give you this drug, but it only works 20% of the time. By the way, it promotes, then it's like in those commercials you've seen, nightmares, your arm might fall off, your nose is going to bleed, and your eye will pop out of its socket. But that only happens 2% of the time. All the patient's going to remember is the doctor gave me the medicine that makes my eye pop out of the socket. So I do try, you have to do informed decision making, but, and so you do want to share the benefits and risks. But if I see this among some of our trainees who are so versed in the science that that's all they present, and they don't give it that humanistic touch, and they don't really offer patients hope. Sometimes hope is the best remedy. And so I always try to impart hope to my patients. And that's part of our negotiation. So Crystal's been nice enough to volunteer to be our standardized patient, and she's going to bring a problem to the clinic. And so what I'd like to do now is a little exercise where we just talk about I'll be the doctor, and she'll be the patient. And if you want to sit over there. And I'll just, what we'll do is have an encounter, and then you guys, just think about it, tell me what works, what doesn't, and then we'll kind of have a conversation about it and go from there. All right. Hi, I'm Dr. Vega.
Hi, Doctor.
It's nice to meet you. And how would you like to be addressed today?
Crystal.
Crystal. Okay. So what brings you to the clinic today?
Well, I've been concerned these past couple of months. I've just been feeling so tired and fatigued, and I've been getting really scared because I feel this numbness over my body. And
Oh gosh.
I'm just getting really freaked out lately. So,
Sure.
I've had these really weird headaches over my forehead.
Mm-hmm.
I feel like my heart is just like popping out. It races so fast.
Wow.
And it's, I don't know, I feel nausea and these weird feelings for the past couple of months, I would say 2-3 months. So I just wanted to come see what's going on with me. I'm getting a little nervous here.
Sure, that's understandable that you're nervous. I mean, that sounds like it's a lot of symptoms. So it's numbness and your heart's racing and with headache.
Mm-hmm.
And it's been for a couple months. Tell me, did anything happen a couple months ago that do you feel like could contribute to what's going on?
Well, actually, I was in a really bad car accident about 3 months ago.
Oh, I'm sorry.
And it's okay. I've been recuperating from the car accident, but my tia, who I'm really close to, she insists that it's from the car accident, that I've had a susto, and I'm getting all these symptoms because of my susto from the car accident. And I see where she's coming from. I can see it because it was a really traumatic experience for me. So I don't know if this is coming out of that car accident, or I don't know how to understand what I'm going through right now.
No, and it sounds and this is very different for you, it sounds like. This isn't your normal state of health. It's just been for those last few months. Usually you're pretty healthy and without a lot of symptoms. What kind of care did you receive after the car accident?
Emergency room, just to check, make sure everything was fine with me, but I've never had a checkup after that. I don't normally have regular follow-up.
Okay, well we can talk about that and hopefully we can fix it. Did the emergency department say everything was okay?
Yeah, they just said my exams, my tests,
Mhm.
whatever they did was fine, and they sent me home, and I thought I was fine after that until I started feeling all these crazy things.
Right. And you had x-rays, things like that?
Yes, I don't know exactly. They took my blood out. I don't know
Okay.
exactly what they were testing.
Uh-huh. Do you remember going through a tube where they took a look at your brain? Did they do what's called a CAT scan?
I think I remember going through a machine.
Okay, all right. We'll get the records, so, but
Okay.
I always like to, it sounds like this has been a, serious set of symptoms for you, and and since it started with a car accident, this is gonna be pretty severe. I wanna make sure there's nothing bad that happened with the car accident that could be contributing.
Okay.
I know you've been talking to your aunt about what's going on. I mean, what do you think about what's going on?
I'm just scared that something wasn't seen during the accident.
Sure.
That some
You mean when
tests
you were
was
evaluated?
exactly
Sure.
that some tests didn't come up positive, or that something was overlooked. That I just think it's a coincidence. Everything's been happening since the accident,
Right.
and I believe my tia that it could be that susto, and I just don't know to what extent it can affect my health.
Have you tried anything for the symptoms that you've had? Anything at all, either like a medicine or a natural product, or any consultation with, with a curandero or with another type of physician or caregiver?
I haven't, but I would consider it,
Okay.
especially in my family. It's common, so they suggest things here and there, and I.
Is that what your aunt wanted?
Yeah, yeah.
I get a sense of that. No, that's fine, and that's good, and that actually can work really well. I do want to make sure that we don't miss something on you, so I'm going to do an exam. But at the same time, I think that we can help you with some of the symptoms that you're feeling, and that they'll get less and less over time, and we want to make that easier for you so you feel more like yourself again.
Okay,
So does that sound good?
that sounds great. Thank
All right.
you.
Okay, that's a pretty brief one, because I cut it short because I didn't want to get too far into it. I think what I probably want to know more about is pervasive thoughts, because susto, is everybody familiar with susto? Okay, so susto is a situation in which it's the great fright, and what it leaves is this lingering sense of a lot of different kind of symptoms are associated with it, but it's marked by a certain event almost always. The last case I had was a middle-aged woman who just went out of her front door one day to run errands, and like right across the street there was a man being beaten by two other guys, and she just her heart jumped. You get that terrible feeling of sick feeling of adrenaline rush, and she felt sick for at least a few weeks after that before she came to see me. And so that's the kind of thing. It's this great fright, and it actually shares some characteristics, but it's its own thing, but it shares some characteristics of anxiety disorders and also with post-traumatic stress. And after a car accident, something bad like that, I think about, could post-traumatic stress be involved here? Is she having pervasive thoughts, nightmares, the things that they are related to susto but could go well beyond it into more a psychiatric diagnosis. And anybody who's been in a car accident, you kind of got the sense that I get worried, oh gosh, maybe she did have brain injury that was not diagnosed appropriately that could give at least some of these symptoms. So she's going to get a thorough checkup, and I'm going to get the records, and so we're going to go over things. So it was a little bit more brief from the medical side, but mostly just to kind of give you a sense. And you were great, because thank you very much. That was awesome, because there was a lot of symptoms that came out right away, and that can be a little intimidating, but it's also a real blessing, because she's explaining everything. And I got a sense right away that she was very comfortable and that she wasn't going to hold anything back. This is something, somebody's putting everything out there. I'm talking too much. What do you guys think about what happened? What was good and what wasn't so good? Yes?
I liked how Dr. Vega reacted to everything. He didn't just stare blankly at her, just let her talk the whole time. He really sounded genuinely sincere and, kind of put off by the symptoms. Oh, that is a big deal. Not well, whatever. You're anxious, probably,
Yeah,
Which I've seen-
whatever doesn't fit.
Right, which I've seen with some physicians. So I like that you reacted to everything.
Yes. If you guys ever hear somebody who, who's got a you know, personal crisis, and if you don't say, I'm sorry at the end of it, or something, you know, empathetic, like, I will find you at whatever clinic you are in our system, and I will like say, what are you doing? Like, it just kills me. Sometimes we'll be videotaping our residents, and, you know, they're like, oh, I just got back from Mexico, you know, my father passed away of SEO, and it's just like the resident's like, mm-hmm. And it's like, oh God, I just want to run in the room and say like sorry, and then like close the door. It's just awful. So yeah, those little statements go a long, long ways, and I mean, people do notice that. That is that personal use moment that's so important to medicine.
I was just gonna say, right at the beginning, when you went in, said hi, gave her your hand, and just asked her, how would you like to be addressed? I think that was really important, because you didn't just immediately like show her your authority, even though you're the doctor, and you were showing her that you care about what she thinks right away, like from the first thing. Because I have seen other doctors who just go in and blah blah blah, start talking right away without really acknowledging the other person. And like you said, some people speak Spanish and everything, but they might not. Or some people might say Mrs. Gonzalez in there, but they really go by another name, and it's just their paperwork. So I like that. I appreciate that, because that's like first impressions, right?
Yeah, no, you can just take that. It takes this is as fast as I would go in clinic. You know, it's balancing the personal side and the efficiency, but it takes, that's so easy, because that's you know, you spend the 3 seconds to make eye contact and to ask that question. You let the person, you know, physicians on average clip patients off at like 9 seconds into their story. But if you let them speak, the average time is like 38 seconds. So that's an extra 30 seconds, but still, you know, you're going to get all the history out. And the patient usually, honestly, knows what they have. They just have to kind of walk around. You walk around until you find it together. But truly, they usually know, and they usually understand what the, you know, even what the best course of therapy is sometimes. So yeah, it's taking those moments do go a long way. Other comments? 1, 2.
I think it was really good how you got the information from her. It's just very efficient in a way that it still seems like you guys are having a very good interaction. It seems like she was able to trust you really fast, but also you got all the information that you needed from her, like what kind of tests that you have, and you used the language that she understood. It's like the tube, were you in a tube? You know, it's kind of important to kind of find out how to communicate with others and make sure that they understand what you're saying.
Yeah.
So I think that was
Oh, thanks. Oh, I was going to throw something back at you guys. So what's the way that you determine a patient's language preference? How do you do it? And it's different when you're called in for like medical interpretation. That's not fair, as you probably know at that point. So it's perfectly fine. But like for the unknown patient, you know, how do you do it? Yeah.
Well, if you have access, if they fill out forms and you have access to that, like the way
That's
the
cheating.
form, yeah, that's true.
But that's smart. That's a smart cheat. I like it.
No, yeah, that's like how we did it, sort of.
Yeah.
But yeah, of course you first you can say, or you can just say, ask them directly.
Yeah.
Or in Espanol or in English, like something like that, just so that they know like right away.
Yeah.
That you're not making an adjustment, you just want to know. Like, or you
Habla
can just
español o
say,
inglés. Prefiero
Yeah.
español o inglés, señor.
Yeah.
Something like that. I
Or
like
if
to
you-
prefer because a lot of people, you know, most patients have some bilingual capability, so it just kind of puts it out more like, what do you prefer to speak?
exactly. Or if you already made like you went in and already spoke to them in Spanish and they looked at you and they
Yes.
speak English, you just say, oh, I'm so sorry, I was just talking Spanish the whole day, I'm so sorry. It's
Claro.
just like
That's
automatic and just immediately apologize. So that way they know it's not because of what you thought
Yep.
of them, but what you were doing before. You just,
Absolutely.
So-
That's great. That's great insight. Yeah, you're absolutely right. Yeah, I mean, the patients know because they've been in our waiting room. They listen to language being spoken out there while they're sitting there for a few minutes. So.
I think one of the ways that I use is I let them know that I speak both languages, so I can say, hi, my name is Paula Gutierrez. So
Yeah.
they kind of get an idea of like how they want to respond to me if they answer in English or Spanish, I'll go with that.
I once had a Russian patient, and so she was at the end of the visit, and she had her family there. So we used the language line, but then I was also talking to the family. She wanted her son and daughter in the room with her. But at the end, I just said "Dos vidania," which is I think goodbye.
yeah.
And I'm sure it's sort of pronunciation, but I got it from like a James Bond movie. But it's just so funny because her eyes lit up, and then I was like, oh, and then I was like, oh gosh, no, I got nothing. So it just showed the power of it. I mean, I felt so sorry for her because it was just awesome to see her like open up, and it was just like, we have to find you a Russian-speaking physician. We must find this. You will be so happy. How you're going to save the patient.
I was just saying, when your interaction, you validated everything she said. You know, you validated her symptoms, and you let her open up to what her aunt had been telling her, and also asked her directly, what do you think it is? I think that was just, you gave her concerns validation, which I think is really important.
When you're kind of lost, when you're kind of lost in terms of symptoms, and this happens a lot in primary care, I think it would happen to any physician. There's so much going on, and you're trying to draw the thread, and you're thinking back to your days in anatomy and physiology, and you can't find something. Ask the patient what's going on, because that will put you on a track where you might be able to answer things. You know, sometimes I ask that, and literally the person just starts crying, and it's like, okay, this is going to be very telling, and you're getting to a different level now. So asking that question, or sometimes it could be like, oh, it's, I've been, I had a patient who worked in a factory, and she had wrist pain, and she had a splint for was carpal tunnel, but most of it was just a terrible overall tendonitis and being arthritis in her wrist. But she was banging them, and when the machines got stuck, she would bang it with her splint, which didn't help her wrist at all. But so that's when I asked, I was like, oh, okay, this is something we might be able to fix. Don't use your splint to bang on the machine. So, I mean, asking that can yield some good things which get you much closer to the diagnosis. Because like I said, the patient knows. They're just kind of, you're just kind of clarify things, reassure them about the really bad stuff, because it usually isn't.
I like the fact that you didn't just disregard, like, the part where she talked about the stuff, because, like, I've seen, like, physicians kind of rolling their eyes, or just kind of like, oh, okay.
Yeah.
And
It's terrible.
you just thought it was a valid answer, that maybe it was something related to that, or there was a motive underneath that, or.
SUSTO, I think, is one of the most important culture-bound syndromes in my clinic that I see. I see it regularly, and my radar for it, it's always out there, pretty close on my radar. So and you can usually figure it out in a few simple questions. And it's also something where there's really good native natural therapies for it, and there's actually a really good kind of Western medicine therapy for it. And the two are totally, that's what I was saying, is I kind of hinted the fact that you can use both because they're very complementary. You can use both very well. I haven't asked you, most importantly, Sarah, how do you think it went? Did it go okay from your perspective, because you were in it?
It went great, I think so. Especially at the end, I think it was really important that you outlined what you were going to do. Like you mentioned, you were going to ask for my records,
Right.
and see what kind of tests they did, and your plan. And I think it's really important to tell the patient what you're going to do, because a lot of times they have no clue what's going on with their own health care. So for you to outline that for me, it gives me, as the patient, it gives me peace of mind that I'm in good hands and I'm in good care.
So anything constructive, thank you. Anything constructive, things that didn't go well or you wish were different, you can see different. Go ahead. Okay. All right. So thank you. Let's have a seat. So let me think of it. I've got any other pearls of wisdom. It takes time, and that journey is really important. So some visits are going to go great right away, and some it's going to be like, it's like pulling teeth, and it's hard. And just remember, it's what you bring into the room too. And if you're exhausted and you're thinking about the exam you have in a few hours, trust me, if you were able to like get a video of yourself when you had that pressure and when you didn't have that pressure, you are different and you act different. So I think the way I look at it is it's like I'm always trying to better myself. I'm always trying to adhere to some of these goals and some of these ideals they have. And I'm always interested in learning new things too, because there's little tricks you can do here and there, and feel free to steal them. That's why you're going to be going in the clinic. Start picking up on this stuff, because it'll put you ahead with your foundations course starting in a few months, and then it's definitely going to put you ahead in terms of being a good third-year med student and beyond. Any other questions or points that you want to talk about? The way I like it. Okay, I've got more examples, but I think that we were going to get to some other stuff now, so thank you very much for your attention. Thanks.